right, as we watch everybody join in, welcome everybody. I'm just going to give a minute for everyone to join us today. I'm going to say we had like 55 that registered last time I checked, so.
Okay.
All right, we're going to
I
go.
didn't know what the topic.
Now they know what the topic is, yes. All right, I'm going to go ahead and get started with our intros. Good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. Welcome to today's program. So as you connected, we've got our chat function for questions and answers. So please go ahead and use that chat function. Your phone or your computer microphone will be muted. We have our post-webinar evaluation. Go ahead and fill that out. I will be sending a thank you email to everybody, and especially for our EMS and our EMT crews. Again, welcome to all of you. Thank you for your service, and you can respond to that thank you email, and I will get your certificate sent out to you. We have CME credit for this as well for all of our physicians, and there is a login process for that. Here's our continuing medical education information. Of course, as you registered, you saw all of this information, so I don't need to read through it, but just for your review again. Our standard disclaimer. I don't need to read that either. You can all read that. All right. And again, be sure to check our webinar for upcoming, check our website for upcoming webinars and events. We are going to have kind of a round table coming up in November, which is going to be fun and entertaining, of course, with our crew. And then in December, Dr. Klotz and Dr. York are actually they're doing another webinar for us on HIV and their experience with the ADOC and the clinic that they run there. It is HIV Awareness Month, so we're going to have that. And again, your opinion is valuable to us, and you'll hear Dr. York talk about how it's from those comments that we get ideas for future topics. So please be sure to do that evaluation. The login code for the your attendance is in there, and plus I'll have all that information in my thank you email if you have not registered for the Cloud CME. So today we have Dr. Ampel and Dr. York with us again today. And of course, we've got Dr. Klotz, as you can see him. He's joining us from somewhere in the Midwest, where it's a lot cooler than it is here in Tucson. And Dr. York, would you like to go ahead and talk about our lecture series?
Yeah, so do me a favor, if you're new to us, say something in the chat, more just out of my own curiosity. But if you are new to us, this is a lecture series we've been doing for the last couple of years now on envenomations, intoxications, travel-related diseases. We started off focusing more in the Southwest, and now we've expanded to include some little bit of different topics, maybe some things not quite in the Southwest for some folks. But these are 1-hour talks that we try to do at least once a month for you all. And I think we've got a lot of folks here right now that work in emergency rooms. We've got a lot of EMTs, and I think we got some veterinarians that are in here too. So we're trying to get y'all covered. Next slide for me. But we are trying to pick some interesting topics, some infectious disease, some related to the creepy crawlies that we've got here. Some things maybe folks have heard of, some maybe they haven't. But really in the last 6 months, about a year, we've been focusing on some of the lesser known things or more obscure areas, including today. But a lot of the feedback that we get from you all is really what has guided this program, as Melanie said. So please, if you all have suggestions, things that you're interested in, let us know. We do have quite the repository at this point of talks that we have done, but as was mentioned, we're looking to maybe bring some folks back, do more of a roundtable approach, and maybe give some different perspectives on some things, have more of an open discussion, hopefully bring you all in with us to have that discussion. But on the list here, goodness, I think we've covered just about everything. It has been a busy year now that I look at this list. I think we've about covered it. All right, but last but not least, we are joined again by Dr. Neil Ampel, Valley fever expert, infectious disease expert, man who has seen everything, been everywhere, and an all-around cool guy. So take it away.
I don't think I can go on after that. So this will be a case of travel-related medicine, and maybe not as much interest to EMT, but to others, I think this will be surprising. I got alerted to this case in my role as a consultant for the Arizona Department of Health Services. And I was so surprised by it, many of my infectious disease colleagues were. I thought it's worth sharing with you today. Let's see, there we go. So let's go over the case. This is a 76-year-old man from Prescott who was admitted to Yavapai Regional Medical Center with a sore throat and fever 3 days after undergoing a bronchoscopy because of a persistent right lower lobe infiltrate. The past medical history is significant that he had polycystic renal disease requiring 2 renal transplants, the last in 2022. He had traveled to Goa, India from April to October in 2024. Around February of 2025, he noted a persistent cough with a pulmonary infiltrate. He was given amoxicillin clavulanate without clear improvement. On May 8th, 2025, he underwent a PET CT, which revealed a metabolically active mass in the right lower lobe. And because of this, he went down to Phoenix to Banner University Medical Center on May 28th and underwent a bronchoscopy with robotic biopsy of the mass and an EBUS-guided lymph node biopsies. And these were noted to show caseating granuloma that were negative by Gram, AFB, and silver stains. As I mentioned, he was admitted 3 days later on June 1st because of fever and sore throat. He was given linezolid, piperacillin, tazobactam, and doxycycline empirically, and he improved over the next few days. A blood culture was obtained and through a gram-negative rod identified as Burkholderia species, but not further identified. And TB quantiferon, histoplasma, urinary antigen, and coccidioidal serology were subsequently noted to be negative. So he was discharged after 5 days on doxycycline. The Burkholderia, by law, had to be sent to the Arizona State Public Health Laboratory, excuse me, and that was found to be a Burkholderia pseudomallei. And because of that, the patient was brought back and given a 2-week course of intravenous meropenem, followed by a longer course of oral doxycycline. At the state lab, genomic analysis was done. That's the identifier. And what was noticed, it was PCR positive for Burkholderia pseudomallei, but they couldn't grow it, but it was sent to CDC and they were able to grow it and confirm that it was pseudomallei. And later on, one of the bronchoscopy specimens was also PCR positive for pseudomallei. Whole genome sequence was done using single 16S ribosomal RNA. That was consistent with Burkholderia pseudomallei. Multi-locus sequence typing identified a novel ACE allele, and a subpanel SNP analysis showed that this was related to organisms from India and Bangladesh. So to show you that this is a pretty typical SNP whole genome sequencing. And so the Arizona isolate fits in with sequences principally from India and Bangladesh, and that's shown here in this phylogenetic tree. So there are a lot of interesting issues to this case. So this is a patient with underlying immunosuppression where we always have to be aware of unusual infections occurring. There was a clear travel history to an area that is now recognized as endemic for melioidosis. And the patient was chronically ill with a chronic persistent pneumonia that demonstrated a granulomatous response. And because of that, the presentation was more like some common diseases like tuberculosis or the endemic mycoses, coccidioidomycosis and histoplasmosis. So to most people, those would be the 3 most likely diagnoses. There was a delay in diagnosis. Melioidosis was never considered. And it really shows the importance of molecular typing as not only identifying the organism, but identifying where it came from. One thing I forgot to put on here is this is an example where the organism, when originally isolated, was thought to be a contaminant. But because it was prescribed to send that isolate, any Burkholderia in Arizona must be sent to the state lab for speciation. That's how this case was actually diagnosed. No one had any idea that this was melioidosis until the state lab identified it as a pseudomallei. So what's the history? This disease was first described in 1912 in what was then called Burma. It's now Yangon, Myanmar. And we have a picture of Alfred Whitmore, but not of Krishnaswamy, because he was just a Burmese individual. So in our Western culture, he is perhaps not worthy of a photograph. But they were the two who identified this. And it was in a patient who had a consolidated pneumonia. And this was recognized as really looking like equine glanders. And they were able to identify a fastidious gram-negative bacillus that was similar to the glanders bacillus, Bacillus malei. They subsequently found 38 other cases that were principally associated with opiate injection use. They actually called this morphia injector septicemia. And now it's felt perhaps this was related to using contaminated water for injection. They also used the word pseudomallei because they recognized this was different. And then finally in 1921, Stanton and Fletcher called this melioidosis, or resembling the distemper of acids. And this disease disappeared until the 40s. It was considered a disease of friendless wastrels of Rangoon. There were no reports in Europeans, and so it was neglected. And it also was noted to have a real clinical diversity of presentation, localized skin ulcers and abscesses, bacteremia with septic shock, and as in our case, chronic pneumonia resembling tuberculosis. So what's the biology? This is a pretty typical aerobic gram-negative bacillus. On gram staining, you can see bipolar staining, and the arrow points to that. And it does have flagella, and it is mobile. It grows very readily on blood and McConkey, so it shows up within 24 hours and may become dry or mucoid after 48 hours. You can see that in the photographs. And it has these biochemical reactions. For those of you, as I used to do, go down to the lab and query the microbiology technicians about the biochemicals. And so it's oxidase and catalase positive. It reduces nitrate. It doesn't ferment sugars. And it's indole, hydrogen sulfide, and urease negative. And for those of you know, that's kind of like a Pseudomonas. We'll come back to that in a moment. It is a facultative intercellular pathogen, and it is a tier 1 select agent of bioterrorism. Recognize that this is an ecologically active organism that can spread by aerosols. So one must be careful. Now, B. malei, the cause of glanders, which is an equine disease, is closely related to pseudomallei. It actually is derived from it. It underwent genomic reduction, so it actually cannot live environmentally. It only can live as an obligate pathogen in horses and related species. So here's the classification. And originally, as I sort of hinted at, these were all classified as pseudomonads. But Yabuchi and colleagues did some 16S ribosomal sequencing and said this is different. So we're going to name this after Walter H. Burkholderia, who in 1949 isolated the organism associated with onion sour rot. And we'll all know this. This is Burkholderia cepacia, which is a common infection we see in the hospital and in patients with cystic fibrosis. So they named it after Walter. So that's where Burkholderia comes from. There are these two clades. Clade 1 is pathogenic, and you can see them up there. If we do this, there's cepaceae, and you can see malei and pseudomallei are quite related and quite distinct from cepaceae. And we also see there's a lot of species, both pathogenic and even more that are non-pathogenic, because as I've already indicated, Burkholderia, many Burkholderia are environmental. So the genomics of this has 2 circular chromosomes that add up to about 7.24 mega base pairs. Pseudomallei shares a core set of genes with other members of the genus. 86% of the genome is common among all strains, but 14% is variable. And some of that variability probably accounts for virulence. Even in patients, there's substantial genetic diversity. So why is this a pathogen? As I've indicated, it is facultative intracellular motile saprophyte, so it can live in the environment. You can see up in the cartoon, there's a flagellum. It has lipopolysaccharide and a bunch of other factors. What this organism does, it is phagocytosed readily, but can escape the vacuole and replicate in the cytosol, and then escape from the cell and cause cell-to-cell spread. And that's probably its key virulence factor. And this is encouraged by these secretory systems like the T3-SSS, which delivers molecules to the host cytoplasm. The T6-SSS promotes intracellular survival, and these actin-based membranes allow it to float around the cytosol and then get out. And because it can survive intracellularly, that gives us latency. So patients will often present months and even years later after exposure and infection with the organism. So the immune response is what usually occurs with the gram-negative. It does have pathogen. It does bind to pathogen recognition receptors because it has pathogen-associated molecular patterns like lipopolysaccharides. So toll-like receptors and NOD-like receptors help initiate an innate immune response that recruits neutrophils, macrophages, lymphocytes. CD4 is important, cytokine upregulation. And so you do eventually get humoral and cellular immunity after infection. The ecology is what's very interesting. There's a picture of a lowland rice paddy in northern Laos. This is a typical breeding ground for Burkholderia species because it's an environmental saprophyte. It lives in soils up to a depth of 1 foot, and it comes to the surface when that soil gets wet, like during monsoon or during agricultural disturbance. In water, it can survive in biofilm and within amoebae. It is killed by chlorination and UV light, and it can become aerosolized during severe weather events. That probably occurred during Hurricane Helene, and that may be occurring now during Hurricane Melissa in the Caribbean. So Burkholderia, in addition to soil and water, have a lot of other environmental niches. For example, they're in the rhizosphere, so they actually help plant roots fix nitrogen. They can be plant endophytes, that is, within plants, and they're found in a lot of wild and domestic animals and in fecal material, and that contributes to the dispersal of the organism in the environment. So what's the epidemiology of this? Well, this is, originally we thought this was a disease of Northern Australia and Southeast Asia. Most of the research is done from individuals in Australia. So Northern Territory and Northeast Thailand are the most endemic, and in fact, it's a very common cause of mortality in Thailand. And then Malaysia, Singapore, Vietnam, Cambodia, and Laos are other areas. And of course, Myanmar, although we don't have much recent data from Myanmar because of the current government situation. But beyond that, melioidosis is now recognized as endemic in 48 countries. And recently, the Indian subcontinent, southern China, Taiwan, and other areas, including the Americas and Africa, have become recognized. The annual case numbers are about 165,000 with 89,000 deaths, but that may be an underestimation. And typically, cases are associated with land disturbance and water exposure, like monsoon season, where there's inhalation of aerosolized bacteria in individuals with skin abrasions or other injuries, or ingestion of contaminated water. The occupational risks are clear: people in agriculture, particularly rice farming, and in construction. So what may be driving the spread of melioidosis? Well, first, if we can say it, can we say it, Larry? Climate change.
Things we can.
And again, increasing rainfall, temperature, extreme weather events. I'll mention later about Hurricane Helene in Georgia. But again, we're seeing a massive hurricane now, which if we had endemic Burkholderia, would be a real driver of that. Zoonoses are very important. I've already mentioned that shedding into the environment by domestic and wild animals can disperse the organism. And then our risk factors, human risk factors, increasing aging, diabetes mellitus, chronic renal disease, chronic liver disease, and of course, transplantation and chronic immunosuppression, as our case today suggests. So this is where melioidosis occurs in the darker red color. So we see the very dark red, northern Australia, spreading through Indonesia into Southeast Asia and India. We see in the Americas, South America, Brazil, Peru, Colombia, and Mexico. And we see that little square of Mississippi, and I'll come back to that. Now, originally, melioidosis was not considered endemic in India, but it's pretty clear that it is. So extensive soil sampling has shown a pretty wide environmental distribution, and there are 20 to 52,000 cases now. The overall prevalence remains underexplored, though. The majority of cases are from southern India, but there are an increasing number of papers suggesting northern India and western India emerging. And I think I put, that's Goa. So we can see from this map, that is not, that is a recognized area of melioidosis, and that's where our patient resided before returning home. So what do we know about this disease in the United States? So in general, it was thought to be extremely uncommon, and most instances were sort of fomite exposures. So we can see household products. So there was a case in Maryland associated with a home freshwater aquarium, and it was very unclear what the source was because the woman bought everything from one store, I believe in Baltimore. So was it the fish? Was it the aquatic plants? Was it the gravel or water, or all of those? But clearly it came from imported material used in that aquarium. Interestingly enough, and my friend Stan Derazinski at Stanford reported on this, there were 4 cases in multiple states associated with spray aromatherapy imported from India. This was sort of an oil therapy. And that was reported in the New England Journal back in 2022. And a little bit later, the CDC discovered that a pet raccoon, and I think you have to ask yourself several questions. Why would you have a pet raccoon, and why would you allow it to step onto the contents of your aromatherapy liquid? But the raccoon unfortunately passed away from exposure to this very same aromatherapy material. Puerto Rico is considered endemic based on serologic and soil sampling, and at least as Bad Bunny tells us, that is part of the United States. So that is the known endemic. But then in 2022, there were 3 cases over a 3-year period linked to environmental exposure in the Mississippi Gulf Coast. And Pseudomallei was isolated from puddle and soil near the home of 1 case. And patient and environmental samples were all by sequencing clonally related. So that's why we saw that little bit of orange on the map. But in 2025, after that map I showed you was prepared, there were 4 cases of presumptive autochthonous melioidosis in Georgia. And these were between 1983 and 2024. And as I mentioned, 2 were associated with Hurricane Helene. Again, extreme events with lots of water, lots of wind. And 2 of those, they shared a common work site with exposure to mud, dust, wind, and 10 inches of rain. And again, these were all sequence type related, sequence type 41. So we've seen now 2 outbreaks in continental United States that were clonally related and associated probably with environmental exposure. So if we look where those 2 came from, this is again the sequence map showing this, and we can see the Georgia strains all related, one area, and the Mississippi strains there, and just, this is the Arizona isolate. I just sort of drew in, showing that the isolate we have that the state lab identified is quite distinct from those Georgia and Mississippi isolates. So what do we know about melioidosis in Arizona? We only know that there's been one case of possible autochthonous or homegrown exposure, and that was from Pima County. That was a 32-year-old man who had diabetes, and he presented with knee pain. And blood, knee aspirate, and sputum all grew Burkholderia pseudomallii, and there was no travel or other exposure history. So David Engelthaler, who some of us here know very well, he's now with ASU Health, did genomic analysis. So he confirmed that this was pseudomallii, and using a multi-locus sequence testing, these were identical to isolates from a patient in Australia. And whole genome sequencing grouped these from genomes from Asia and particularly Thailand. So you can see this clade. It was an Asian clade. So to this day, we don't have any idea how this patient acquired Burkholderia pseudomallii, and that remains a mystery. So how do people present with melioidosis? Well, first of all, infection is usually acquired by exposure in the environment, either non-intact skin, inhalation, or ingestion. And because of those three mechanisms, that leads to very different clinical manifestations. Environmental conditions probably increase risk of exposure. So as I've already said, tropical storms or monsoons, occupations with outdoor exposures, mostly occurring during rainy season, because that's bringing the organism to surface, getting the organism into water. Most infections are latent, we don't pick them up, but active disease usually occurs with certain risk factors: diabetes, liver disease, chronic lung disease, chronic renal disease, and in our case, immunosuppression. And disease can either be acute or chronic. And that gets, so if we take our case, it's hard to know which it was. He was clearly ill by February, and he had come back to the United States in October. So was he had active infection all the time, or did that become latent and then reactivate? We don't know. So the incubation period is usually 1 to 21 days. And as I've said, you can have a prolonged onset of symptoms after infection. And the manifestations are manifold: pneumonia, bacteremia without focus, genitourinary tract infection, skin infection, and osteomyelitis. And this is from very nice Nature Medicine, showing all the manifestations, but I think the big ones are 40 to 60% present with the pneumonia, 40 to 60% with bacteremia, and up to a quarter with skin lesions. So just to show you what some of these look like, this is from a New England journal. Most of these are, so you can see cutaneous abscess. This was almost certainly an inoculation exposure. Here's a pneumonia with a huge cavity in the left upper lobe. On the plain chest X-ray and CT scan from another paper shows a very dense upper lobe infiltrate. So again, that looks all the world, particularly like coccidioidomycosis. And then here's a bacteremia with dissemination, so you get multiple skin lesions as part of this. So how to diagnose this? Well, it's actually not very hard, such as in our case. Pseudomallii grows readily on routine media, and it did. They got a blood culture, and it grew readily. What's interesting is when we look back at the BAL on biopsy, they actually did not send that material for culture, for bacterial culture. And so, because the staining was negative, and obviously had they done so, we would have had a few days heads up, I'm sure, I'm sure those would have grown had they been cultured. You can do PCR, but it's less sensitive than culture. And you would do serology only really for epidemiologic purposes. Now, the pathology is what's interesting. So you can get what you would expect from a gram-negative rod, necrotizing and suppurative inflammation with abscesses. But what's strange about pseudomallei is you get granulomatous inflammation. And when I was first to learn about this case, I could not believe. That's when I started to learn about melioidosis, because I said, this just doesn't fit. Why aren't I seeing neutrophils or an acute suppurative reaction? But in fact, for reasons that are unclear, pseudomallei causes this caseating granulomatous inflammation, so it can look all the world like tuberculosis or other granulomatous infections. And that's what our case did. And that really, at least threw me off and probably others. Well, and it did account for why cultures weren't done, because they knew that this was granulomatous. So they just deferred a routine culture, which we know now probably was not correct. So what about antimicrobial susceptibility? We should just think of this like a Pseudomonas. So like a Pseudomonas, it's not going to be susceptible to penicillin or ampicillin or first generation or even second generation cephalosporins. But unlike Pseudomonas, it's actually resistant to aminoglycosides and polymyxin, which we don't use much, but fluoroquinolones. So those are usually our go-to antibiotics for a gram-negative rod, and they're not going to be effective for melioidosis. So what antibiotics are active? Extended spectrum beta-lactams. So amoxicillin clavulanate is one. Now, our patient didn't seem to really respond to that, so there might have been resistance. We don't know. We don't have antimicrobial susceptibilities. As you'd expect, anti-pseudomonal third-generation cephalosporins like ceftazidime and carbapenems, and just like Pseudomonas, not ertapenem. Remember, ertapenem is a carbapenem that has no activity against Pseudomonas, and it has no activity against Burkholderia pseudomallei. Trimethoprim sulfamethoxazole, Bactrim, has been used. There is some resistance depending on geography, but it's classically used. This patient got doxycycline. I wasn't involved in that decision. Probably not a preferred therapy, but it turns out it is effective and resistance is uncommon, so it can be used. And just to show you, this is a paper from 2014, just looking at antimicrobial susceptibilities with ceftazidime, doxycycline, meropenem. We can see that most strains are susceptible as they are to TMP SMX. So those are usually the antibiotics one would use. And again, these are isolates from Northern Territory, Australia. So what about treatment? There are two stages. There's the initial phase and the oral eradication phase. The initial phase, we would use either a anti-pseudomonal penicillin, like ceftazidime, or a carbapenem, either meropenem or imipenem, and many experts would combine that with trimethoprim sulfamethoxazole, and that would go on for 14 days. And then you'd have the oral eradication phase, which is 3 to 6 months, usually of Bactrim, but some people would use doxycycline. And then, very importantly, if you have abscesses, like for any other infection one wants source control, you should drain those. And apparently that's particularly true of prostatic abscesses when you have a GU infection. So again, you can see both the antibiotics and the dosage for treatment. So I've ended pretty early, so we can have a lot of discussion. Maybe I'm talking to, but I think this is a really emblematic case because Burkholderia pseudomalia is an environmental bacterium. It causes a variety of infections, particularly in compromised hosts. Solid organ transplants are at risk. A travel history is critical for determining the risk of melioidosis in the continental US, since it is so uncommon. It is important to note that pseudomallii grows readily on routine media, and a positive culture is conclusive, but the laboratory either needs to do that speciation or send it to the state lab to do that. So our case is very important in the fact that the laboratory did send it on, and only then was the diagnosis established. And then I think, you know, hats off to the Arizona State Public State Lab for doing this terrific molecular analysis, because what it showed is it not only confirmed the diagnosis, it absolutely established that the patient likely got this during his residency from April to October in Goa, not likely, almost certainly did not acquire infection in his time in Prescott. Okay, so that's the talk, and if we have questions, I'm happy to entertain those.
All right, let's see if we can.
Well, while we're waiting for other questions, thanks a lot, Neil. That was fantastic. And it made me think of when I was in Vietnam doing HIV work. It was known as melioidosis was known as tsunami lung. So after that huge tsunami, and I don't know what year that was, there were lots of people who died because of, you know, inhalation of all this seawater, but it had come from the soil. And as far as I remember, that 32-year-old man, his presentation was mainly bacteremia. He went on bacteremic for a month. Every day. He was over at Tucson Medical Center, and so I was aware of that young man.
Yeah, so Steve, you know, yeah, that's where I thought he was at TMC. But yeah, where that organism, how he acquired that.
Well,
So,
one
have
thing
any
that
thoughts
came
on
up at the time, yeah, one that came up in the history that Cliff Martin did on him was that he worked on motorcycles that were shipped from Nam to the USA, and they cultured all these motorcycles at his shop. He lived in Safford, and they didn't find any, and they didn't find any in all these potted plants he had. There were a lot of tropical plants. They were, you know.
yeah, I didn't see any environmental workup, so that's interesting. I didn't know he was from Safford. Yeah, you'd think, but for Burkholderia, yeah, would be hard to imagine, you know, just the metal frame of a motorcycle. It would have to be
supported,
damp. Yeah, sort of like the aquarium in the Maryland case.
yeah. I
So
agree.
Sally, you had your hand up. Did you have a question?
Oh, she just dropped. Was the team involved in bronchoscopy of the patient at risk of exposure to the organism via the biopsy?
Yeah, they were, and I have to check. I believe the state health department through Maricopa County did alert them, but I'm going to have to go back and check with them, because that's a great question. So this is, yeah, this can be passed on. So obviously with a bronchoscopy, and of course they should be wearing masks and eyewear during a bronchoscopy, but they would be at risk, particularly during a BAL. And I believe they were alerted but that would have been a week or so afterwards. I don't know that anyone got any prophylactic antibiotics, and I'm going to ask Guillermo Adame is my colleague at the state lab or the state health department in Vector, and I'll re-ask him about that. That's a great point.
The other thing is maybe if one of the veterinarians is on still on the line, is that I know we occasionally had cases of glanders when I was a child on the farm, but I mean, not we, people did. And as you had mentioned, it's just strictly confined to horses. But it can be contagious, I think, in the proper setting.
So I think one big takeaway from this, especially with our EMS and our EMT people, is getting that history. Especially with people that travel, because there's been other topics that we've had that you've talked about. It's like, well, wait a minute, where have they traveled that it's coming back here it isn't necessarily
Yeah.
from here? Right?
And I will tell you, I don't think, when he did get admitted, people were aware that he had visited India. But I will tell you, looking at the notes, when they saw gram-negative rot in the blood, Burkholderia species, it was dismissed as a contaminant. So to me, yeah, and point taken, I wouldn't have thought of melioidosis. That would have been, in fact, I didn't when the case was presented to me. So, but that history is, yeah, that has to come into it. I don't think it was even before the admission, because he was, that led to the bronchoscopy. And the saving grace here is the state saying you must submit this organism as a tier 1 agent for speciation. That's how the case was picked up. Otherwise, he would not have been diagnosed.
Wow. Interesting.
But yeah, the travel history, and we're still trying to get that about, and the epidemiologists are very interested, did water fall on, when he was there, I think during the rainy season, was he exposed to water? Where was he exposed to water? We're writing this up, and to me, the real points are that travel history, immunocompromised patient, very unusual disease, granulomatous. Those are the keys. And really the bacon was saved by the culture, because otherwise you wouldn't have a diagnosis.
No, absolutely. And, and also in NAM, this was a disease that we used to see in returning veterans from Vietnam War. I mean, the key that I always think about, and I hadn't thought of these other things, was that to think, well, it looks like TB. Well, the guy was in Asia. And I always go, well, melioidosis, but.
All right, well, that's sometimes where you think, and I was just talking to Kareem Shihab about this, where AI-assisted diagnosis, because it would have put it, there's no question if you abstract this case, you say, I've got a renal transplant who just came back from Goa, who has a granulomatous pneumonia. What are the possibilities? And he lives in Arizona. So it would have said 3 things: TB, coccidioidomycosis, but it would have said melioidosis without bias. And I think this is where we get into our biases. And that's what you just did, Steve, because that's thinking
Right.
fast and slow. That's the slow thinking. That critical issue. And you remind me, I didn't see much recent literature, but you're absolutely right that soldiers during the Vietnam War were at enormous risk, because that's a classic exposure. You're wandering through the Vietnamese jungle. So melioidosis was occurring in the 60s and 70s in U.S. Ground troops, but we don't see obviously mentioning that now.
Right. And it could be in the environment from just those folks returning and spitting and whatever. But, your comment about AI is perfect, because Larry is actually making our AI thing for HIV care. And, I think the advantage there is it just iterates itself over stupid stuff we wouldn't think about.
Yeah, well, and in fact, when I talked to Kareem, both of us said, though, this is the thing. It might have said your 3rd most likely diagnosis is Burkholderia. It certainly would have said that if you had a positive blood culture for a gram-negative rod. But again, because of the way humans work, we would have said, nah. But it would have at least put it there in a less biased manner.
But it does bring up that question. So then someone commented, this is such a bizarre disease. Why would the lab think it was a contaminant?
Because it is a bizarre disease, so they just and again, remember, he came in because he had, he came in after the bronchoscopy, so this was all related. You've had a bronchoscopy, now you're febrile. And I left, he also had a very resistant E. coli in his sputum. So again, there were these other things where, and he got better pretty quickly when they put him on this rather unusual concatenation of antibiotics, which maybe the piptazo, maybe the doxycycline helped. And remember, he was a walking pneumonia. He was only admitted because of so it's a very difficult case, but that's why it's such a great teaching point. I do want to bring up, because I was watching the news hour last night on Hurricane Melissa. So we don't think about this. This is like Helene. This is a Category 5. Jamaica's never seen, and now Cuba, anything like this. Now that's not going to hit the United States, but were we to get another Category 5, a massive hurricane with all that water on the Southeast United States, I would wonder, given what we saw in Mississippi, given what we saw in Georgia, that there would be more cases of melioidosis that were autochthonous.
So we do have another session coming up. Like I said, we're going to do kind of a round table. We're going to bring some of the folks back in and have some interesting conversations, my guess is. Please be sure to watch your emails, and I'll be sending that out to, of course, everybody that has been in our series, let you know first when it is ready to be registered for. Let's see here. So there's a code in the evaluation so that you can log in for your attendance. I will be sending out that thank you email to everybody, so you don't have to worry about writing anything down. The evaluation will pop up when we're done, so please go ahead and fill in that evaluation, and then you can respond to my email for specific PDFs of your certificates. We love all of our EMS and our EMT folks that are with us, and also we've got some of the UA veterinarian group that have been following along, and hopefully we can do a combined webinar next year on Envenomations with the UA vet school as well. Get some really interesting things going on. All right, so do we have any last words?
I want to make one more comment for Steve and Larry and anyone else coming to Portal, because Steve is always desperate, or he's making me present again. Even though I told him that, that you only have so many talks in you, so every time I give a talk, I've shortened my lifespan. But I'm willing to do it again. But this will be presented at our Portal meeting as an unknown. So anybody who's on the call comes to Portal cannot blurt out the answer based on you already seeing what the answer was. Otherwise, you will be severely admonished and won't be able to grill your steak on Saturday night.
Dr. Klaus, anything you'd like to add?
There's a
Oh,
question from
other
Maureen.
than the fact that that was an excellent presentation, and I think, it's all something we need to put in our memory bank here, at least some of this here. And I know because of Neil's last presentation a couple months ago, it's really important we get this AI going in some fashion that actually works for ID. Are you going to do one, Dr. Ampel? Make one?
Well, I'll get, my son is now at Georgia State, and he graduated from MIS, Ben.
Yes.
And he is an AI guy, so I can talk to him, or I think Dr. Chen, who is the Regents professor, we could talk to somebody either here, or I can talk to Ben. But there must be programs. So we should explore those. Because I think, that's one of the problems, somebody asking, well, this is such a bizarre case, but we really become victims of the common. And again, I love to quote Danny Kahneman, thinking fast and slow. Most of us think fast. It's hard to think slow. It's hard to really, as Steve did, he immediately got that issue with India and an immunocompromised host and a gram negative. But a lot of us, we just don't tumble to that because we just assume it's a more common thing. And most likely that's going to be correct, but sometimes it's not. That's where I think AI helps, but we still have to listen to it and also filter it. That's the other thing I'm going to say is AI, general AI is a problem. I just came upon on Perplexity a false reference. Said that Josh Mello had published something in 2024 and he didn't. And that was on Perplexity, which is usually pretty good. So we do need to be careful, but we need to interpret AI. And as Ben taught me, AI is best if you're already in a skilled area and you're using it to assist you. If you don't know what you're doing, it may not be as helpful as we tend to think it might.
That's important to remember, absolutely. I do want to say that we are going to have a webinar in 2026 on everything AI in telehealth. So we've got our new director and the team that has joined us. They're going to be talking about AI and everything AI in the healthcare, and it's going to be a great webinar. I don't have the date yet, so be sure to follow our website and our events. But when that comes out, I'll be sure to let everybody know when that's going to be scheduled as well. All right, so we've got just a couple of minutes left. Any other final comments? We're looking forward to Portal. That is I'll be down there. I'm going to be doing some recording of the interesting talks that are going to go on down there. And again, thanks to Chris Martin, who's been helping us out for the last few years with this Envenomations series, and along with all my other webinars. Here's one more question: Is open evidence reliable for most physicians?
I haven't used open evidence. Have you, Steve? I
No.
haven't had yeah, so I don't know. So that would be one that's, I think, the most common one people are using. I would just say for everyone though, and the way I use AI when I use Perplexity, and I don't know if open evidence does this, hopefully so, you get references. So I go to the references. And as I said, I just can't, which was the first time, but it still was pretty shocking coming up with a reference that didn't exist. So it's still worth looking at what it gives you. This is the same with UpToDate too. You read that, but then go to the primary references if you're using it to make sure that's what people actually wrote.
Dr. York, anything to add?
I got nothing to add to that. I can't remember what the study was that was discussing like the effects of using AI on different individuals. And I think this was more in the creative spirit, that if people use AI more to bolster or maybe to get ideas for something they already have some awareness or knowledge about, I think you saw an increase in productivity, creativity that then did start to dip down after. And when you withdrew it, it was almost like you were taking away a drug, and that they did struggle then in its absence to have that same level of creativity. So I'll be honest, it's funny that we're working on this AI project because frankly, it scares the heck out of me and it's going to turn my brain to sludge. And it has been really fun to get to experiment with it. Even the thing that we're using is about as basic as can be. And just that is a fairly powerful tool. Wow. If it's trained right. And that's the issue.
So a couple of things. So in fact, Ben, we were just talking because I saw him in Atlanta. So the first thing, AI is a little bit like GPS. We become less skillful. We're all less skillful in navigating roads now because that's absolutely true. It's not a joke, Melanie. And AI will do that. And I actually used Perplexity when I started to write the publication for this. I asked it to write an introduction, and it really inhibited my ability. So it's really great because it's just like you say, it can give you ideas, but it can take away your creativity very quickly because it frames it for you. And it often writes very well. And then you're locked in to its structure that you didn't create. You asked it a question. Write an introduction on a transplant patient from Arizona who traveled to India who has melioidosis, and it did a great job. But I was then very inhibited from thinking, what do I really want to say? So that's a problem. And we have that with all these mentally assisted devices. They take away our flexibility, mental flexibility.
That's scary.
It is. That article scared the heck out of me. I won't lie. I think it's a worthwhile tool. I think it's just how you use it is key.
And Ben confirms that. He's also, just to mention, so this is he is working with MIT to use AI for Python coding, which is how you write. And they had to go to Georgia State because everyone at MIT is like a master of Python. But it's the same thing. So it can be very useful, like in coding, it's really helpful because it avoids a lot of errors. But again, people aren't going to be as good at coders because they're going to be dependent. So use it with care.
In moderation, just like a lot of
Everything,
everything in moderation.
The parallels to this being a drug of abuse, or it's.
Yes.
They're there, they're absolutely
Oh, I didn't
there.
realize, so that it's Ron that asked that. So, hey, Ron, good to see you. And yeah, I haven't used open evidence yet, so I'll have to try to do that.
All right, thank you everybody for joining us again. Greatly appreciate it. And we look forward to seeing you on a future webinar. And be sure to check your emails. I'll send that thank you email a little bit later today, and you can respond and I can get those certificates out. So with that, I'm gonna give you back 4 minutes of your day right now.
Oh.
Right? Thanks, everybody. You have a great rest of the day.
Thank you.